So today's class is very critical. And when I say very critical, it is really, really critical, right? I really want you to be able to ace any topic as far as headaches are concerned, because headaches are really, really, really big. So far as your practice and everything you have to do is concerned. So today we're going to a pattern we have recognized candidates love to do our learning. That is to use equations. So I'm going to present almost all the causes of headache you need to understand so far as your board exam is concerned. I'm going to present them to you, and then we are going to solve them one by one by one by one. So today I need you to get some water and make sure that you are ready to go with me. So let's start from here. I want us to make headache differentials easy to pick up in your board exam. And today's class is going to focus on that and that alone. And we're going to use equations for that. Okay? So please, before we start, don't forget, hit on the like and the subscribe button. Also share this link with as many friends as possible. As many friends as possible. Just share this link with them, because this class is going to really, really be awesome. Okay. So I'm going to start with headaches you cannot miss. Because don't forget that in the board exam, you need to know the life-threatening causes of various things. So whether you have abdominal pain, whether you have chest pain, whether you have headaches, whether you have even skin rash, right? What are the emergencies a candidate must not miss? What are the emergencies a candidate must not miss? And that is where we are starting from. So, number one, so let's all work on this differential. The patient comes in, the patient says that this is the worst headache of my life. There is either loss of consciousness or not, and there is also probably neck stiffness. Today, we are just working with differential diagnosis. What is your answer? The patient says, this is the worst headache of my life. You know, there may be loss of consciousness, there may be neck stiffness. So I just want to see that answer. We need to type fast because we have a lot of topics to go through today. So today we just go. I give you the equation, we deal with the answer, and then we deal with how to pick that particular concept on a board exam, and then we go to the next one. So please, I'm waiting for the answer. Dr. Mosima says SAH, subarachnoid hemorrhage. Does somebody have any different answer? Okay. Dr. Rockefeller also says the same thing, subarachnoid hemorrhage. So I'm going to move on. It is subarachnoid hemorrhage. And how are you going to meet it in a board exam setting? Look out for a middle-aged patient who may be telling that this is the worst headache of my life. And usually, look at it in the context of maybe that patient was exercising or that patient was involved in sexual activity, right? Now, I need you to always think, always suspect aneurysmal fracture. The patient will need to get head CT scan. And then if you do your lumbar puncture, what you should expect in the board exam is that you're going to see xanthochromia. Xanthochromia is like, a yellowish color. So that's the first thing I want you to pay attention to. Okay? Middle-aged patient who says, this is the worst headache of my life after exertion in a board exam. Please think about subarachnoid hemorrhage as a result of aneurysmal rupture. Next best step, you may need to get a head CT scan. If you do a lumbar puncture, you're going to see xanthochromia. First things first. Let's go to the next case. Patient presents acute headache, and you notice that there are focal neurologic deficits. And you also realize that the patient is hypertensive, and you are presented with this head CT scan. What is your answer? So acute headache, focal neurologic deficits, and you're presented with this CT scan. What is your answer? Hmm. I'm seeing some answers. Pseudotumor cerebri. Not really. Some also say subarachnoid hemorrhage. Not really. What Charlotte says intraventricular hemorrhage. And that is the answer. That is intracerebral hemorrhage. So let me go back so you can look at the image very well. And I'll even make it so big that I'll get out of it. Please. This is how intracerebral hemorrhage looks like. Intracerebral hemorrhage. This is how it looks like. Okay. So in your board exam, please don't miss anything like this. Don't miss anything like this. Headache plus focal neurologic deficit plus hypertension. Look at the distribution of the bleed in the head CT scan, right? Intracerebral hemorrhage. So what is the context? What's the clinical context? Usually look for a patient with high blood pressure, and the whole thing is that there's sudden headache, and you notice weakness, and the patient may vomit. Okay? This patient is literally bleeding into the brain tissue. So what you need to do is to look for signs of focal neurologic deficit, and this patient needs to be treated urgently. This patient needs to be treated urgently. So intracerebral hemorrhage. Know how a patient with intracerebral hemorrhage will present. Next one. This patient had, there was a lucid interval. So it looks like the patient got a little better, and then rapid deterioration. Head trauma, lucid interval, rapid deterioration. And then you're presented with this CT scan. Let me make it bigger. You are presented with this CT scan. Head trauma, patient had lucid interval. Then the patient started deteriorating rapidly. What is your diagnosis? Good. Dr. Rockefeller. Beautiful. Beautiful. Dr. Rockefeller says epidural hematoma. Does somebody have good? So let's go. So this is epidural hematoma. This is how a patient with epidural hematoma will present. So the clinical context is look for a young patient who had head injury. The patient will wake up fine, and then the patient will collapse. Look like in your board exam, look for those checks, right? You have a patient had a head injury, the patient woke up, the patient is fine, and then the patient collapses again. And the artery, which is usually affected, is the middle meningeal artery. Please note this very well. These slides are really loaded. Okay, middle meningeal artery. That's where the bleeding is coming from. And when you look at it, it looks like an apple, right? Or a grapefruit. So those in MedCognito, you realize that I've dealt with this extensively in your notes. I think in neurology or emergency medicine. So look at the way it appears on a CT scan, because this is what will help you to ace it on it. Okay, the artery which is affected, write this down in your book, is the middle meningeal artery, and there's a biconvex picture on the CT scan. Beautiful, beautiful. Okay, now let's talk about this one. So you have a patient. That patient had a minor trauma. The patient is elderly. The patient is anticoagulated. So maybe the patient is on rivaroxaban, dabigatran, or the patient may be on warfarin. And then the patient develops gradual confusion with headache. Remember, today's class is on headache, and we are trying to find out all the various presentations of headache. And we are dealing with life-threatening causes. And then you get a CT scan, and you see this on CT. What is your diagnosis? What is your diagnosis? Remember, we've already dealt with epidural hematoma. We've already dealt with that. And I'm presenting you with a totally different picture, right? Good. So I see Dr. Anna says it's subdural hematoma. And that is the correct answer. Subdural hematoma. Subdural. So Dr. Rockefeller says something here. Elderly patients with confusion, banana shape. Beautiful. So the epidural is grape shape. Subdural is banana shape. Okay, and I'm explaining this extensively in your MedCognito. Dural is grape shape. Subdural is banana shape. So look at the way it takes like the form of the cranium, right? The form of the skull. It looks like a banana, right? Good. Let me even get a banana and show you. My brother bought some bananas yesterday, so let me get a banana and show you. Okay, so there we go. Yesterday, my brother bought a banana. So you see that it takes the shape. It takes the shape of the skull, right? So that's a skull. Meanwhile, if the skull is like this and then the bleeding is like this, then you are thinking about epidural hematoma. Please, does that make sense? So if it takes the shape, so think about the skull this way, and then the bleeding takes the shape of the skull, you are thinking about subdural. And then if the skull is like this and then it goes the opposite way, then you're thinking about an epidural hematoma. Please, does it make sense? I want to know the banana analogy. Does it make sense? Awesome, awesome. Okay, now let's go to the next one. Let's go to make use everything possible to teach. So don't worry. Okay, so you see what I'm talking about. So the banana shape is there, right? It takes the shape of the skull. Beautiful. Okay. So the clinical context is the patient had a fall and the patient is gradually, declining, gradually becoming worse and worse and worse and worse. So this one is a venous bleed and it's a crescent shaped connection on the CT scan. That is the interesting thing. Okay, so now let's go to this patient. The patient has a headache, the patient has neurologic deficit, and the patient has vascular risk factors, so like high blood pressure, hyperlipidemia, diabetes. What's your diagnosis? Headache, neurologic deficits, vascular risk factors like diabetes, high blood pressure, hyperlipidemia. What's your diagnosis? By the way, doctors, please don't forget, MedCognito has so many goodies for you. So I need you to go, you're already on the YouTube channel. I need you to click on the like and the subscribe button right now. Okay? We have so many doctors on our YouTube channel right now. We are sitting at 3,340. I want 50 more people to subscribe today so that we can get to, in fact, 60 more people so we can get to 3,400 subscribers. Okay? So, and by doing that, it helps other people see the channel and grow the channel. So, what is your diagnosis? Okay, someone says CVA, cerebrovascular accident. So that's it. Richard Asari got it back. This is a stroke, right? This is a stroke, simple stroke. So look for an older patient with sudden weakness or speech difficulty. And usually in strokes, like the headache will be less, but it can occur if there's a large vessel. Okay, so this is a stroke. This patient presented a stroke. So far, we are looking at the life-threatening causes of headache. Because whenever you are learning, what you need to do is you need to start with the life-threatening, and then you can move on to the next life-threatening causes, right? So life-threatening causes of headache. Okay, good. So now, this other patient, this patient had a sinus infection. The patient said had facial, developed headache, and the patient has eye movement problems, and there is also fever. There's also fever, sinus infection plus headache, plus eye movement problems, plus fever. What's your diagnosis? What's your diagnosis? What is your diagnosis, doctors? What is your diagnosis? What is your diagnosis? Sinus headache, sinus infection, headache, eye movement problems with fever. Our answer is cavernous sinus thrombosis. Cavernous sinus thrombosis. Cavernous sinus thrombosis. So the clinical context is look for a patient in a board exam. Look for a patient with recent sinusitis or a recent facial infection. Look for a patient with recent facial infection. Okay. And then the patient then goes on to develop double vision, diplopia, and the patient may have eye swelling. After this class, I need you to send me notes you've done on all these topics I'm going. Now, usually in cavernous sinus thrombosis, the venous clots can compress on cranial nerve 3, cranial nerve 4, cranial nerve 6. And what you need to remember is this is life threatening. It is life threatening. You need to really, really pay attention to it, right? It can be life threatening. Cavernous sinus thrombosis. So if you've not really written orbital cellulitis, you know, but this is the typical presentation of cavernous sinus thrombosis. Remember, we are learning board exam stuff, right? Board exam stuff. Okay. So let's go to the next one. The patient has recurrent headaches. That's what you are told. Number two, they are associated with seizures. The patient has neurologic deficits as well. Recurrent headaches. There are seizures associated and neurologic deficits. Recurrent headaches, seizures, and neurologic deficits. What is your diagnosis? Tell me. What is your diagnosis? Hmm. Neurologic deficit. So epilepsy. You want to check your answer again. So some are saying epilepsy, some are saying orbital cellulitis, no. Recurrent headaches plus seizures plus neurologic deficit. Your answer will be acute malformation. So look for a young adult with seizure and chronic headaches, like they develop headaches over and over and over again. Whenever they develop the headache, they have a seizure. It's so bad that they develop a neurologic deficit as well. This is how an arteriovenous malformation in the brain can present. So what you have to think about is that usually there's single blood vessels and they may rupture and they may bleed. Okay. So another serious cause of headache that you cannot miss in your board exam. You get a patient with headache, and you are told that the patient has jaw claudication. So headache plus jaw claudication plus visual symptoms, eye symptoms. See you, eye symptoms. So headache plus jaw claudication plus visual symptoms. What is your diagnosis? Headache plus jaw claudication plus visual symptoms. What then becomes of your diagnosis? Good, 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 good. Temporal arthritis, GCA, beautiful, beautiful. This one, a lot of you got it right. So temporal arthritis, right? So in the context, look for an elderly patient with scalp tenderness when they comb their hair, right? This is how it presents. And if you don't intervene quickly, those patients can develop blindness. Now, what medication do you give? You need to give your steroids, high dose steroids. This patient needs to see two specialists. Number one, ophthalmologist. The patient also has to see an ophthalmologist as well, right? Um, and even a rheumatologist as well. So you want to make sure that you on your boards, the ESR will be high. The C-reactive protein will also be high. You may need to put temporal artery biopsy for this particular patient. This patient has temporal arthritis. Temporal arthritis. All right, please. Are you tracking with me, doctors? Are you tracking with me? With the way we are going through the class, are you tracking with me? I want to know, please. Are you tracking with me? Before we move on to the next one, are you tracking? Are we tracking together? Are we tracking together? Beautiful. Let's make these board exams very, 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 very simple. Ridiculously simple. Okay. Let's keep it very simple. Okay. All right. So remember, temporal arthritis. If I don't intervene early, the patient can become blind. Scalp tenderness, jaw claudication. As the patient is combing the hair, it may even be painful, right? The patient may even have associated polymyalgia rheumatica as well. Okay, good. Let's move on to the next case. This patient has neck pain, unilateral headache, Horner's syndrome. Neck pain, unilateral Horner's syndrome. Neck pain with unilateral headache plus Horner's syndrome. I give you this trial. Three. Neck pain. So maybe right-sided neck pain, right-sided unilateral pain, Horner's syndrome on that same side. What is this? Tell me something, doctor. Tell me something. Neck pain. No, 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 no. This is not migraine. Neck pain, unilateral headache, and Horner's syndrome. So that means there's something on that one side. Horner's syndrome. That is the so maybe they may have ptosis and hydrosis on that side, right? They may not be sweating on that side. These are the features of Horner's syndrome. So why would a patient have neck pain? Neck pain, unilateral Horner's syndrome. Why? Please, the answer is artery dissection. Carotid artery dissection. So look for a patient who had a minor neck trauma. The patient then develops a drooping of the eyelid. Okay, there's a drooping of the eyelid. So usually, if you see a young person who has developed stroke, think about carotid artery dissection. Young person who has developed stroke, think about carotid artery dissection. How are we putting this together? Let's go back. Oh, Dr. Rockefeller says, okay, yes, neck pain because of that trauma, right? The patient developed headache from there. And then the patient developed drooping of the eyelid. So that's why I didn't put drooping of the eyelid, but I put Horner's syndrome. So what I'm trying to say is that you also need to know the features of Horner's syndrome, right? Notice, you know what? When you are learning, you need to be able to break these concepts down one by one. Because in the board exam, you're not expecting to get all the clues in your question stem, right? And one thing I'll suggest is take your time, go to the Medical Council's website and download, download the 5 questions. Now they've even developed it into a PDF as well. Okay, download that and take your time and look at the way they set the questions. That will help you to really prepare very well. But don't expect to be given all the clues of the in the question stem. No, don't do that. You'll be setting yourself up for disaster. You may just be given a few clues, like what they provided in their free question samples and even the ones which are stored on their website. So neck pain, natural headache, Horner's syndrome. So you have to know the features of Horner's syndrome, and that is what will lead you to carotid artery dissection. Right. Okay. So now we are done with those very serious causes of headache. So who can list them for me? Who can list them for me? We did stroke. We did subdural hematoma. We also did epidural hematoma. We did venous sinus thrombosis, right? We've done what else? What else have we done? What else did we do? We've done, let me just check, venous sinus thrombosis, stroke, epidural hematoma, subdural hematoma, intracerebral hemorrhage. We've done all this, right? We've done, um, yeah. So we've covered quite a number of things in the serious causes of headache, which you need to make sure you've covered. We've also dealt with temporal arthritis as well. So now let's deal with headaches and the central nervous system itself and infection. So you have headache plus fever plus neck stiffness. Headache plus fever plus neck stiffness. This is easy. This is easy peasy. So just tell me, what is the answer then? Yes, we dealt with arteriovenous malformations as well. So now we are dealing with CNS infections. So headache plus fever plus neck stiffness. Headache plus fever plus neck stiffness. What would be your diagnosis? Beautiful, simple. Meningitis, right? Meningitis, simple. So look for either a college student or look for a patient who is immunosuppressed or look for a patient who lives in a crowded area. The patient presents with fever, vomiting, photophobia. I can't look at the lights, right? Headache, neck stiffness, meningitis. What will you do? You will do your lumbar puncture. You treat the patient with dose of antibiotics. So at times you can do like ceftriaxone plus vancomycin, big one. And in some cases, some people will also suggest that you give steroids to prevent deafness. But most of the time, that is seen more in encephalitis, right? So look for a college student with photophobia, vomiting, headache, neck stiffness, fever. Get your lumbar puncture. Make sure that the patient doesn't have symptoms and signs of raised intracranial pressure. Treat the patient with antibiotics right away. And while we are doing that, I also want you to learn how to interpret CSF fluid, cerebrospinal fluid. If I present something to you, you should be able to tell, okay, this is tuberculous meningitis, this is bacterial meningitis, this is viral meningitis. You should be able to look at the various parameters in there and be able to tell me easily that Dr. Bruni, this is this, this is that, this is this, this is this. Okay. Next case is you have a patient with headache plus fever, and the patient has vesicles on the lip, and the patient has confusion, and in some cases they may have seizures. Headache, fever, vesicles on the lips, confusion, seizures. Headache, fever, vesicles on the lips, confusion, and then sometimes seizures. What is your answer? This one I'm not going to provide answer until I see at least 10 people provide me the answer. What is your diagnosis? Headache, fever, vesicles on the lips, plus confusion or seizures. Someone wrote meningitis. Hmm, it is close. Good. Dr. Kofi Ejapon says herpes encephalitis. Dr. Emmanuel Ogumozo says herpes encephalitis. Exactly. Why? Because of the vesicles on the lips. Because of the vesicles on the lips. Because of that information I put there. Vesicles on the lips. You know, in a board exam, please always be like a detective. Be watching what is presenting, what is presenting. Okay, boom. Because of this, I know what I like. So it looks like everyone is getting it right now. It's like everyone is getting it right now. Okay. Let me just send something. Come in. Okay, sure. So this is how encephalitis will present. Okay, so usually look for a young person with altered level of consciousness, personality changes, and when I give it a clue of vesicles, think HSV. This patient needs urgent eosinophilic. Okay, or look for a baby who was recently kissed by somebody. Kissed, right? So that's why it is dangerous to be kissing babies because you have like force around your lips. You can transfer that to the baby. Boom, that can cause trouble. This patient needs antiviral treatment and needs to be admitted to the hospital right away. Herpes and encephalitis. Okay, so you have a patient with headache, fever, focal neurologic deficit, and you see the CT scan, headache, fever, focal neurologic deficit, and you see this CT scan, headache, fever, focal neurologic deficit, and you see this CT scan. What is your answer? Headache with fever with focal neurologic deficit. What is your answer? Aha. Headache with fever, focal neurologic deficit. What is your answer? And please share the link, share the link, share the link, share the link with your friends. Share the link. Oh, okay, I'm seeing something. Toxoplasmosis or schistosomiasis. No, no, no. Toxoplasmosis. No, 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 no. Toxoplasmosis. No, 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 no. What is the correct answer? The correct answer for this patient is very simple. It's a brain abscess, right? This patient may be, and the way I'm presenting it, headache plus fever. That fever there speaks more for brain abscess than toxo. And yes, toxo, you have to look for that in like in an immunosuppressed patient and all those things. But in this case, headache, fever, focal neurologic deficit with this ring lesion, please think about brain abscess. Good. So Dr. Richard Asari said, sorry, I missed that. Yeah, sure. So it's not toxo, please. It's not toxo. So look for a patient who the board may present with having ear infection or sinus infection, and now the patient has focal neurologic deficits, right? Ring enhancing lesion on imaging, and you need to get the neurosurgeon to drain this right away. And the patient needs antibiotics, heavy dose antibiotics, heavy dose antibiotics to deal with this particular situation. Okay, so this patient, the board tells you that the patient presents with early morning headaches. Early morning headaches, vomiting in the mornings, especially. And the patient has been developing progressive neurologic deficits. The neurologic deficits are worsening, and the headaches are in the morning, and the patient has vomiting. Dr. Nadia, beautiful. Dr. Nadia can beautiful. She says this patient has a brain tumor, headaches which are worse on waking up and relieved by vomiting. Think about raised intracranial pressure. This patient needs imaging so that you can see the tumor. This patient needs to see a neurosurgeon so they can plan on whether or not they are going to remove this tumor and decide whether this is even operable. Brain tumor, headache, worse in the morning, vomiting, and the neurologic deficits are progressive neurologic deficits. That tells me that probably the tumor is growing, right? That tells me that the tumor is growing. Okay. So, doctors, I have a quick question before we move on. You need to answer this gentleman. Do you understand everything we've done up to this point? Do you understand everything we've done up to this point? Because we need to make sure that we understand. Do you understand everything we've done up to this point? Yeah. Good. Do you understand everything we've done up to this point? I need at least 15 answers before we move on. I've seen just 4 answers. Do you understand everything we've done up to this point? Because this is, I think this is the approach I'll also be taking in our lectures, right? So present with equations and then you sit down and think through it rather than just giving you answers. You go like, oh, okay. No, now we'll present with so many equations so that you can be using that to build your knowledge. And don't forget that tonight you have a class, right? Tonight you have an MCQA1 class with MedCognito. So don't miss that as well. You have a class this morning. Or this evening, sorry, tonight. You have a class this evening. Let me even check the topic you are doing this evening. So today is September 21st, right? Okay, so today you have a gynecology class. Okay, sure, Dr. Joanna Decree says gynae, beautiful. Okay, so let's move on. Now we're going to deal with other causes of headaches. So you are presented with a patient who was at the movie theater. Movie theater. In fact, we've dealt with this recently. At the movie theater. And then the patient developed headache. And you realize that the patient has severe eye pain. And the patient has halos around the eye. Halos when there is light. Patient at the movie theater. You hear that? Okay. Dr. Boni is trying to give me a clue. Headache, severe eye pain, halos around light. Good. Dr. Musima, good. Dr. Richard, no. Migraine is wrong. This patient was at the movie theater. The place, as soon as the place was trying to get brighter, maybe they were lifting the curtain, boom, the patient had headache. The patient had eye pain. And the patient sees halos around the eye. This is not migraine. This is acute angle closure glaucoma. Acute angle closure glaucoma. That is how the patients will present. And one feature is that the pupil will be mid-dilated to be stuck. Mid-dilated pupil. The patient will present with nausea, vomiting. The patient will have abdominal pain. This is an ophthalmology emergency. Okay? And this patient needs a tonometer right away, tonopen, to check the pressure in the eye. And you need to start giving, pressure lowering medications right away. This is how you pick it up. Acute angle closure glaucoma. Elderly patient, fixed mid-dilated pupil, nausea, vomiting, headache. They may have even some abdominal pain. Remember that acute angle closure glaucoma is one of the non-GIT causes of abdominal pain. Another non-GIT cause of abdominal pain can be sickle cell anemia. It can be porphyria, right? It can be lower lobar pneumonia. It can even be an MI, which can present with epigastric pain. Acute angle closure glaucoma. This patient needs tonometer to check the pressure in the eye. Quickly, the patient needs eye pressure lowering drugs like timolol. Doctors, please, are you picking what we are laying down? Are you picking what we are laying down? Are you picking what we are laying down? Because this is very important, right? Very, very important. Okay, so let's move on. Acute angle closure glaucoma. Let's move on to the next one. The patient has headache, photophobia, and look at the eye very well. Small irregular pupil. Headache plus photophobia plus small irregular pupil. Headache plus photophobia plus small irregular pupil. What is your diagnosis, doctors? Tell me. What is your diagnosis? Headache, photophobia, small irregular pupil. This one, I taught it when we're doing the acute angle closure glaucoma. I mentioned it as well. Headache, plus photophobia plus small irregular pupil. What is your diagnosis? Everyone is quiet. Chippers. Everyone is quiet. Headache plus photophobia plus small irregular pupil. Okay, so if you don't know this, let's get into it. This is a case of iritis. Iritis. Okay, when the patient opens the eye and exposes the eye to light, there's a lot of pain, and the patient has headache as well. Usually, it can be associated with an autoimmune disease. Now, I have a question. Which autoimmune disease is iritis associated with? Which autoimmune disease is iritis associated with? Which autoimmune disease is iritis associated with, or diseases? Okay, so someone mentioned sarcoidosis. So autoimmune diseases which are associated with iritis, think about ankylosing spondylitis. Okay, number 2, think about reactive arthritis. Number 3, think about psoriatic arthritis. Number 4, think about inflammatory bowel disease like Crohn's disease. Number 5, think about sarcoidosis. Number 6, think about rheumatoid arthritis. Number 7, think about systemic lupus erythematosus. Number 8, think about Behçet's disease. Behçet's disease. Behçet's disease. Okay? And then even juvenile idiopathic arthritis as well. Can I take it again? Please, doctors, if you're tracking with me, these are the various autoimmune diseases which are associated with iritis. I'm going to go over them again. Number 1, think about ankylosing spondylitis. Number 2, think about reactive arthritis. Number 3, think about psoriatic arthritis. Number 4, think about inflammatory bowel disease like Crohn's disease. Number 5, think about sarcoidosis. Number 6, think about rheumatoid arthritis. Number 7, think about systemic lupus erythematosus. Number 8, think about Behçet's disease. And number 9, even think about juvenile idiopathic arthritis. Please, did you write that down? Did you write that down? Did you write that down? Doctors, did you write that down? Did you write that down? So somebody was asking me, and I want to put, Jogreen can also, someone is asking me, is iritis the same as uveitis? You realize that uveitis is the broader term, right? Which is talking about inflammation of the uvea, which is the middle layer of the eye, which includes the iritis. So iritis is a subset of uveitis. Okay, iritis is a subset of uveitis. So I need you to pick that up and don't miss that. Okay, so iritis, please know all the autoimmune conditions which are associated with iritis. Make sure that you know it. Please make sure that you know all the autoimmune conditions which are associated with iritis. Okay, now you have a patient with pain with eye movement. The patient has also developed painful vision loss. The patient is a young woman and has headache as well. Patient is moving the eye, there is pain. Okay, painful vision loss, young woman plus headache. What's your diagnosis? What's your diagnosis? Pain with eye movement, painful vision loss, young woman, headache. What is your diagnosis? Drum roll, and the answer is optic neuritis. Optic neuritis. Optic neuritis. Okay, so please, in your book, write, how am I going to learn how optic neuritis presents? Optic neuritis. How does it present? So look for, in the board exam, a patient with painful eye movements, Patient is developing vision loss. The patient is a young woman. The patient has headache. Boom. Optic neuritis there right away. Okay. And they have decreased color vision. And which condition is it associated with? Multiple sclerosis. Multiple sclerosis. Multiple sclerosis. So you realize that this exam, like when you're dealing with a board exam, you must be able to recognize patterns. And if you bring that into your medical practice as well, it makes you a wonderful physician. Go like, okay, this, that. Boom, it's this. This, that. Boom, it's that, right? Optic neuritis goes with multiple sclerosis. Okay, again, do you understand what we've dealt with so far? Do you understand where we've gotten to so far? Again, do you understand where we've gotten to so far? I'm very happy about the participation and the way we are picking things up gradually. Are you okay with where we've gotten to so far? Doctors, don't hesitate. Please share the link with as many friends as possible. And if you've not clicked on the like and the subscribe button on our YouTube channel, please do that right away. Do that right away. Okay? Click on the like and subscribe button right away on YouTube so that as soon as we post anything, you'll be getting a post notification. Okay, sure. Let's move on to the next point. Now let's deal with some primary headaches. Okay, this one we'll run through it. Patient has unilateral throbbing headache plus nausea plus photophobia or phonophobia. Unilateral throbbing headache plus nausea plus photophobia or phonophobia. This is very simple. Everyone should know this. This one, you have to type your answers right away. This is very, very simple. This is very, very simple. This is very, very simple. Very, very simple. Very, very simple. Migraine headache. Beautiful. Migraine headache. Migraine causes recurrent disabling headaches, and it's usually triggered by stress, right? And there can also be hormonal imbalances that can lead to it. The patient may have an aura, visual flashes, or the patient may have zigzag features. So this is simple. Migraine headache will present with unilateral throbbing headache, nausea, photophobia, or phonophobia. You need to learn for your exam how to manage migraine headaches. What are the medications we can give? First line, second line, right? Okay, let's move on to the next one. Next one, patient has headache, but there's band-like pressure around the head. The patient does not have any neurologic deficits. Headache, but there's band-like pressure around the head. No neurologic deficits. Headache, but there's band-like pressure. Beautiful. As soon as you hear band-like, it leads you to one thing: tension headache. Tension headache. You realize that the patient may be going through some stress. There's a tight band around the head, and it's the most common primary headache, and it is benign. Tension headache, not cluster. Tension headache. Tension headache. Okay. Now this patient I'm presenting to you has severe unilateral pain around the eye. Patient has crying, lacrimation, right? It's not like the patient is sad, right? The headache is causing lacrimation. The patient is restless. Patient is restless. Severe unilateral orbital pain, lacrimation, restless patient. What is your diagnosis? 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 The diagnosis is boom, cluster headache. This one looks like a lot of doctors are getting it right. Cluster headache, according to Dr. Musima. Cluster headache, according to Dr. Nadia Khan. Rockefeller cluster. Dr. Hanks cluster. So, look for a middle-aged man. He's pacing, he's uncomfortable, just walking up and down the emergency room. And when you give them oxygen and triptans like sumatriptan, naratriptan, rizatriptan, it helps the headache. Okay, good. Again, does it make sense? Does it make sense? Does it make sense? Doctors, does it make sense? We've dealt with so many causes of headache this morning. So many causes. Okay? let's jump into the next thing. You are in the ER and they bring a patient. The EMS say that the patient was in a cottage. The patient develops headache. The patient is confused. And you look at the lips, they are cherry red lips. Patient was in a cottage, brought into the emergency room. Patient is confused. Cherry red lips. Oh my goodness, beautiful. Dr. Rockefeller said CO poison, carbon monoxide poisoning. And I can even say, okay, the patient was in a cottage, the dog the patient took is dead. Patient is very confused and the patient is somnolent, right? That's carbon monoxide poisoning. Why? Because they were burning something in the cottage, and the patient slept and the patient breathed that in. Carbon monoxide poisoning. Carbon monoxide poisoning. Carbon monoxide poisoning in a cottage. In a cottage. Beautiful. Carbon monoxide poisoning. So just think about this. Why will a patient develop carbon monoxide poisoning and have headache? The patient was exposed to maybe a heater, fire, and you may even be told multiple sick family members may be sick, or an animal which is close to the family is dead. When you notice that should tell you. And you have to check the carboxyhemoglobin. And how do you manage it? You need to give 100% oxygen. You also have to know which patients do you need to send to, a specialist center so that they can get proper treatment for carbon monoxide poisoning, like pregnant patients and all those things, right? You have to know this. Carbon monoxide poisoning. Beautiful. Okay, so I have another patient in the ER. Patient has headache, recurrent sweating, palpitations. Okay. Headache, recurrent sweating, palpitations. Headache, recurrent sweating, palpitations. What is your answer? Headache plus recurrent sweating. Oh, beautiful, 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 beautiful. Dr. Nadia Khan says pheochromocytoma. Pheochromocytoma. Headache plus recurrent sweating plus palpitations. Pheochromocytoma. So you have to look for episodic symptoms of hypertension, okay? And it is caused by a catecholamine secreting tumor. And you've got to confirm that with plasma metanephrine's. Graves' disease is thyroid. No. This is pheochromocytoma. Headache, recurrent sweating, palpitations. Pheochromocytoma. Typical presentation. Pheochromocytoma. Okay. This is very simple. This is very simple. This is very simple. It's just because we are going through all the causes of headache. 34-week-old pregnant patient. 34 weeks pregnant patient. Blood pressure is 178/95 millimeters of mercury. The patient has proteinuria. The patient has headache. This is very simple. This one, even if you are asleep and they wake you up, you should be able to tell me what the answer is. 34 weeks pregnant patient, blood pressure is 178/95 millimeters of mercury. Patient has proteinuria and headache. What is your diagnosis? What is your diagnosis? Well, Dr. Richard, HELP is a complication of the condition, right? HELP syndrome is a complication of the condition, but in reality the answer is preeclampsia. The patient has preeclampsia. Okay, look for that patient who is in the 3rd trimester of pregnancy. The patient has headache. The patient may have visual aura. The patient may have right upper quadrant pain. In worst case scenarios, the patient may even develop anuria. And then if it is not managed properly, then the patient can have a seizure, or the patient can go on to develop the HELP syndrome, right? HELP syndrome, where there can be elevated liver enzymes, low platelets, all those things, HELP syndrome. So you have to know what preeclampsia is, how will you manage preeclampsia, And the medication we give in a patient with preeclampsia is, number one, you need to give your magnesium sulfate. Number two, you need to give your antihypertensives. And finally, the management of severe preeclampsia is that the baby needs to come out. You need to deliver the baby. The baby is already in the third trimester anyway, right? And you're in a first world country like Canada, US, Australia, the UK. The baby will do well in the NICU. So this is preeclampsia. Because if you're not careful, the mother can develop a stroke, but that can die, right? Okay, good. So, doctors, it's been a wonderful morning. I've really enjoyed this. I want to know how many of you enjoyed as we went through the various differentials. This is how I think I'm going to be doing a lot of the webinars as well. You know, diagnosis, but yeah, we can do equations and the rest, right? To help us to get to the various things. Because don't forget that the QE1 is basically focusing on how you're going to take a history, how you're going to do your physical exam, how you're going to investigate a patient, how you're going to manage and complications, and then ethical concepts, right? So if you're able to use equations to come up with what you need, it becomes very simple. So that's my phone number, +1 306 891 5649. +1 306 891 5649. Dr. Rockefeller says, nice session. Oh, good. So, doctors, how many of us want us to conduct the session this way? I want to know. How many of us want us to also have sessions like this where, you know, I bring a particular system which you need to know for the exam and you just go through it like that. Just go through it like that. How many of you want to do that? I want to know, doctor, because with this, that means you're covering so many topics, right? Because remember that the exam is more of objectives than individual topics. So if we can pick one objective and just go through various topics which fall under it, let me know. Okay, awesome. And don't forget, please reach out to me on +1 306 891 5649. +1 306 891 5649. And remember, it's going to be on YouTube, so you can watch it. Don't forget that at MedCognito, we offer you a full package for your exam preparation. You'll have a question bank in your portal, your study portal. You have twice weekly classes, every Thursday and every Sunday evening, right? You also have your own portal, which contains everything you need. So maybe let me just share it with you so that you see exactly what you get. And it is because of how extensive our training is. That's why people are really, really doing well in their QE1. You know, in fact, yesterday, I think some candidates went to sit for the NACOSKI exam. So if you also need help with that, let me know. But remember, my phone number is +1 306 891 5649. I have an emergency shift this morning, so that's why I have to conduct the session this morning. And I think maybe going forward, we can look at moving the session to mornings like this so that we can all have our afternoon. Because don't forget that in the evening as well, you have a class, right? Yeah, in the evening, you also have a class. So we need to make sure that you are getting it. So if you go to the MedCognito portal, okay, if you go to the MedCognito portal, you have everything there. You go to the MedCognito portal, you have everything there. So if it comes to gynecology, rheumatology, we've done all that for you. And all you need to do is you open a particular place, say psychiatry, okay? You see that the first class, which is there, is the live class, a replay of the live class. It's there for you. You can watch it. And what we've also done is that we've put various teachers there, including myself, other teachers, so that if you don't like even this teaching methodology, you can use the other person's teaching methodology. And then all the objectives, you know, so anxiety is one objective you need to master. It's there for you. Everything is there. Everything is there for you. So somatic symptoms and related disorders, these are all objectives you need to cover. If you're not covering these, no. If you've not covered substance use and addictive disorders, you are not prepared for the exam yet, doctor. You're not prepared for the exam yet. So this is what I want to give you as a gift, right? I want to make sure that you are getting all this as a gift. So thank you very much, doctors. Let me stop sharing my screen so we can get back to where we are. Thank you for spending your morning with me. I will keep serving you. That's what we are here for. We'll keep serving you. And all that I talked about. So whether you need help with QA1, whether you need help with Narcoski, whether you need help with therapeutic decision making, whether you need help with your CV preparation. And this morning, those who are interested in CAMS, those who want to go into the residency program, I just did a whole video on CAMS, introduction to CAMS. It's on our YouTube channel, and I'm going to share the link in the comment section right away. So you can even click on it, go there, go check it out. Okay? You can go there, go check it out. It's there. Everything is there. Okay? You can go there, go check it out right away. We just dropped a video on CAMS. So you can go there, go check it out. You will love it. You will love it. Okay? I broke down all the various pathways in CAMS. There are 4 of them. I'm not going to give everything away to you. Just go to, I'll put the link in the comment section. Click on it to watch it. Also, everything we do in MedCognito, especially for QE1, it's only $420 every month. And doctors, you are getting access to teachers who are, in the system teaching. Teachers who are practicing as doctors in Canada. Myself, I'm also here to guide you. And you have a group of other doctors who are preparing with you. You have access to your own portal. You have your question bank. You have your med bullets. So med bullets is like, your final revision before you go for your exam. And you can start doing that right away because we've revised more than 3,400 topics in med bullets alone. Right? In med bullets alone, more than 3,400 topics. You have your question bank med bullet. You have what you call med drills. So med drills, every month we choose some weak areas of candidates and we run, a drill for it. Usually we do it for like 6 hours. And then you also you can do your mock exams privately, and every 2 weeks as well, we conduct a live mock exam. So doctors, we have all these things for you, all the goodies. So if you need help, reach out. If you also have a friend who is a nursing student who needs help with NCLEX, reach out. If you have a friend who is a pharmacy student who also needs help with pharmacy exam preparation, we've started that as well. Reach out. We are here to support you. Doctors, thank you very much for spending your morning with me. Talk to me right away. My phone will be buzzing. So if you want us to speak, just +1 306 891 5649. +1 306 891 5649. Hop on a call with me. Let's get talking. Have a wonderful day. Bye-bye. Bye-bye.